Okay, welcome to the first of 3 parts talking about medical decision making, or in the note, the assessment and plan. First of all, some administrative stuff. I had a lot of questions from people saying that the KIA assignment had very few points awarded. That's probably a fault of the software program. There's no way to give partial credit for the type of answers that we're trying to do, but I will be giving partial credit. I just have to figure out a way either to force Kia to do it or do it manually. So my plan is to have everything graded by tomorrow evening, and then send out the email scores. There's also a lot of questions about, well, does this count? Does this count? What's the difference between this and that? I'm also going to try and answer those questions by tomorrow night. For now, what we're going to talk about the third part of the E&M code, and it's divided into 3 parts. This last part is called the medical decision making, and it's divided into the diagnosis points, the data points, and the risk. So we're going to cover the diagnosis points just for this section. On the worksheet that I have, the diagnosis points are right here, and the kind of the worksheet is this little box right here for diagnosis points. Notice that diagnosis points does not refer to the number of diagnoses. It has to do with the nature of the presenting problem. So there is 5 possibilities. You can have a maximum up to 4 diagnosis points, and that is the maximum all the time. You cannot go over that. A straightforward problem, and this should say 1 point each, is a problem that is not necessarily easy. It's a problem that the patient really shouldn't even be in the office for. So if the patient comes in and they had a rash that's already resolved, that is a straightforward problem. If they have a uninfected insect bite, that is a straightforward problem. It's something that really the physician should not even be seeing. If you have something like a URI or a cough, and they still have symptoms, or they're worried about some sort of infection, then that would not be a straightforward problem. Each straightforward problem is worth 1 point for each straightforward problem that's listed. The next one up, which is also worth 1 point, is a follow-up or chronic problem that is, here it's labeled as stable. The technical term is at goal. So a really good example of this that's clear-cut is hypertension. So if a patient comes in with hypertension and the therapy goal is under 140/90, and the patient has 130/75, then you have one problem that is at goal. You have met the goal. The goal for the physician shouldn't change. There should be some indication as to whether they think that it's stable, unstable. You'll also see compliant, controlled is another word that you'll see used. Pretty much they mean all the same thing, and those are usually the keywords that I use in determining whether something is stable or not stable. Now, if you have a follow-up problem, you get 1 point each. So let's say that you have diabetes, well controlled, you have hypertension, well controlled, and hyperlipidemia, well controlled. That would be a total of 3 diagnosis points, because you have 1 point for each follow-up chronic stable condition. The next level up is a follow-up or chronic problem that is not stable, and those are 2 points each. So going back to my example, if I have a diabetic patient and their diabetes is not well controlled, but their hypertension and their hyperlipidemia are, then I would have 2 points for the diabetes because it's not stable or not controlled, and then I would have 1 point for the hypertension and 1 point for the hyperlipidemia, and then the total would be 4 points, and those would be the number of diagnosis points that I would have. The next category that you can have is a new problem with no workup. Now, workup is specifically these things: any labs, imaging, studies, or referrals. Now by studies I mean EEGs, EKGs, diagnostic tests that don't fall into the category of imaging or labs. If none of that is mentioned, then you get 3 points. Now, if somebody presents with 2 new problems, you have to pick one and ignore the other. You can only use 1 new problem. And I think if you take a bit to think about it, it's pretty obvious that 1 problem is worth 3 diagnosis points. And so if you take 2, you're at 6, you're already over, so it's easier just to take 1 new problem at a time. I also want to define new. Okay, new problem is not new to the patient. It's new to the provider, the physician. So let's take a really straightforward example where a patient comes in and they've been coughing for 3 or 4 days. That's obviously a new problem. But let's say that a patient gets into a motor vehicle accident, they're shipped off to the emergency room, and they do their follow-up care with their primary care physician. That problem has been seen by another provider of a different specialty, and it's been around for a while. The problem is not new to the medical world or the insurance company, but this is the first time the physician is seeing it, the family practice physician. It is considered a new problem. Please don't confuse that with a new patient, which we'll get into next week. A new plus workup, again, you're limited to 1. The same definitions hold. It's just that you'll see a reference to referrals or labs or imaging or things like that. And that is worth 4 points. Now, this does not make sense to physicians. When I present this, this is where I reinforce to them that to the medical mindset, billing does not make sense. Because a URI, which they consider a very straightforward problem, is considered, straightforward's a bad word, very simple problem, is worth 3 points. And diabetes, hypertension, hyperlipidemia, which they consider all 3 of those to be more complicated, are worth 1 point each, and if they're all well controlled, they have the same amount of points as a URI. This is where we reinforce that these are the guidelines, this is the way that we're told to use it, and there's just no way around it. You're going to have to take a firm stand on that, because sometimes physicians will push back and they'll say, well, I don't want my URIs being worth that much. There's nothing they can do about it. I have an example here, an example that we've been using. The assessment and the plan, the plan isn't listed on this particular chart. It should be, and they're kind of lumped in here. The assessment is kind of what, from the physician's point of view, is going on. And so this assessment is lightheadedness. It is a new problem. The physician ordered labs, and so we know that this has got workup. So I have a new problem plus workup. Okay, I've got now 4 points. And so I would circle or highlight or whatever. Actually, I'll highlight it so you guys can see it. This 4 points for the diagnosis. And the next section we'll go over data points. Depending on your specialty, data may or may not be something that you're going to deal a whole lot with. Typically, we don't deal with it a whole bunch in primary care, but a lot of other specialties, cardiologists, neurologists, nephrologists, surgeons, sometimes depending on the conditions, it's a much bigger player. But we will get to that on the next video.